Welcome to the Together Facing Esophagus and Stomach Cancer event. Thank you to all of our patients, caregivers, advocates, and guests for joining us. I'm Crystal Denlinger, Chief of the Division of Gastrointestinal Medical Oncology and the co-director of the Survivorship Program, and I want to welcome you all to our event this evening. Tonight, my colleagues and I look forward to sharing with you some information about the latest research and treatment developments for esophageal and stomach cancers. Although we wish we could have this event in person, we hope that you find this program inspiring and informative wherever you are. If you're watching this and have a Facebook account, we encourage you to leave a question in the chat feature, and we'll get back to you either later in the evening during our live chat section or at a later date via email. At our Together Facing events, we traditionally begin with honoring those that we have lost to cancer. Please join me in a moment of silence honoring those we've lost to esophageal and stomach cancer. Thank you. I'd also like to take a moment to thank our exhibitors for this evening. It's because of their generous support that we can offer this free program to you tonight. I'd like to especially thank our gold exhibitors, Caris and Tempest, and our silver exhibitor, Bristol Myers Squibb. We're also really excited tonight to have the participation of a number of advocacy organizations who have partnered with us and supported us. Debbie's Dream, Esophageal Cancer Action Network, Esophageal Cancer Education Foundation, Hope for Stomach Cancer, and No Stomach for Cancer are all supporting us and joining us tonight, and we thank you all for your participation. So I'd like to kick off this event tonight by introducing our panel for the evening. Each of our panelists brings a unique perspective to the table from their discipline, and I'm hopeful that each one of them will be able to provide us with some information that will be both informative and hopefully encouraging to those of you who are living with and through stomach and esophagus cancer. I'm going to start by introducing each of the panel members, and then I will turn to each one of them to give us a small presentation about a specific topic with esophagogastric cancer. So joining me tonight is Dr. Abbas, who is Chief of the Division of Thoracic Surgery. I have Dr. Stacy Su, who is an assistant professor in the Department of Surgical Oncology and also who works in the Division of Thoracic Surgery. I have Caitlin Gregory, who is a nurse practitioner within the Division of Thoracic Surgery, and Dr. Stephanie Greco, who is assistant professor in the Department of Surgical Oncology, who works with patients with stomach cancer. We have Dr. Joshua Meyer, who is the vice chair of translational research and the chief of GI radiation oncology from the Department of Radiation Oncology, and Dr. Efrat Dotan, who is the associate professor in the Department of Hematology Oncology, our fellowship director and director of our geriatrics program. We also have Jalen Kellogg, who is a nutritional support dietitian, and Susan Haney, who is a social worker and leads our esophagectomy support group. And I'd like to thank each of them for participating in this event tonight. So we have a lot of information to talk about, and I want to get all of your opinions about your specific topic of interest. So we're going to kick it first off with the surgical perspective. And I'm going to start with Dr. Abbas. Dr. Abbas, I'd like you to tell us a little bit about what's new in surgical techniques, what's new in surgery for esophageal cancer.
Thank you, Dr. Denlinger. Again, it's a pleasure to be here and to meet with our wonderful patients. Esophageal cancer, as you know, continues to be really the scourge of cancer in this country and worldwide. And unfortunately, until this day, whenever removable, surgery continues to be the mainstay of treatment for this disease. So we really try to capture esophageal cancer at what we call the resectable stage, where we can actually remove it and all the lymphatics around it. This operation used to require really a morbid operation, requiring big incisions in the abdomen, in the chest, in the neck, and really required a very long recovery time. I'm happy to say that nowadays, especially in centers of excellence like Fox Chase, we can do these operations in a minimally invasive fashion. As far as the access to the operation, it's all done laparoscopically or thoracoscopically. And I think what's new and exciting is using the robotic technology in treating this disease. It really makes this operation that again used to be quite extensive, more similar to a minimally invasive operation. Of course, that doesn't make it a minor operation by any means. It's still a major operation. But I think we can get the patients recovered a lot easier using robotic technology.
That's great. So it sounds like we are moving forward in being able to get people up and around after esophagectomy and back to life a lot sooner with our minimally invasive techniques. But what happens after an esophagectomy? Dr. Su, I'm sure that you spend a lot of time talking to patients before and after esophagectomy about what to expect in terms of life afterward. But what do you typically talk to your patients about what they're facing after esophagectomy?
Thank you, Dr. Dillinger. One of the questions that patients most commonly pose is, how do I eat after my esophagectomy surgery? And I tell them that the types of foods that they end up eating will be of normal types, but the way in which they eat will be different. It will be more frequent, smaller volume. We try to focus on eating about 6 small meals a day. So that might be 3 meals with some snacks snuck in between, focusing on high calorie foods and high proteins. It does require some planning and strategizing throughout the day because the patients will have to figure out how to get enough fluids in between eating foods and fluids. You know, it's all about managing the volume limitations that accompany a lack of part of their esophagus and stomach. It also may mean avoiding certain problematic foods, dried breads, dried meats, and learning to chew thoroughly so that the food is almost emulsified when they swallow. We also emphasize the importance of activity, of walking after eating to help with the digestive process and to help just decrease that sense of fullness that patients often report, but end up getting used to after some period of time. We emphasize not eating within a few hours of sleeping because patients do remain at high risk for something called aspiration, which is when foods or other secretions fall into the lungs instead of going downstream into the gut. And that may also involve sleeping at an incline, never lying flat if they can help it. So patients are often advised to either sleep in some modified recliner or to sleep atop pillows, just supporting them so that their head of the bed is higher than the horizontal.
Great, thank you. So Caitlin, you are someone as a nurse practitioner that spends a lot of time with our post-esophagectomy patients. And I know you and I have shared many patients and realize we think alike when talking to our patients. So as an NP that works with these patients, what are your words of wisdom, both in the initial post-treatment period, post-esophagectomy period, and then some of the long-term things that you talk to your patients about over time?
Yeah, thanks, Dr. Dunlinger. I think that one of the big things in the preoperative portion of diagnosis and kind of getting everything squared away is the fear of the unknown and the anxiety that comes with a cancer diagnosis, and really just having a little bit of patience with the workup because it is multifactorial, and we want to do our due diligence to make sure that our plan is customized to the patient and that they're on the right path for the cancer and the stage that they have. In the post-op setting, like Dr. Su said, the diet is just such a central part of the recovery. Pain is everyone thinks pain is number one with surgery. It's really diet after esophagectomy that kind of follows our patients through for a bit of time. And really just having patience, there is a general plan for getting back to a diet. But it's customized for every patient. So we just follow the journey with you, and you have a full team, in your corner to make sure that you're progressing at your own pace. I tell patients that, some people, live to eat. I live to eat. And after esophagectomy, you kind of eat to live. So you're kind of grazing all day. And it really is a little bit of a lifestyle change for many patients who are used to 3 square meals a day. And there are lots of tips and tricks that we've learned, that we've gotten feedback from our patients over the years to really customize, some education for our patients, and, sometimes we say eat on a salad plate so that your plate looks full, but you're not overeating. Portion control is can be a huge hurdle for some patients. And then, at the end of the day, we never really say goodbye. This is a lifelong relationship. So we're always there. And, sometimes problems come up a couple of years after surgery, and we're only a phone call away. And I think that that's what's special about Fox Chase, is that it's a lifelong relationship with your team, and we're not going anywhere, and we're always here for you.
Great, thank you. So Dr. Greco, you are someone that treats a lot of stomach cancer as a surgeon. And while we've talked a little bit about the esophagus cancer issues, stomach cancer issues are similar but different. So what are some of the considerations you talk to your patients about when you're considering a gastrectomy, or in patients who are post-gastrectomy and are now sort of entering that survivorship period?
Thanks. And thanks for having me here. I think when it comes to stomach cancer, one of the first things, that patients ask is, how much of their stomach is going to be removed. So, there are different types of gastrectomies. And obviously, as we go towards a total gastrectomy, just like Dr. Sue and Dr. Abbas said, patients, their immediate reaction is, well, how can I eat without a stomach? How will that work? And so I think, there's kind of a wide range of expectations, depending on what type of surgery they'd be getting. So a patient who's having a partial gastrectomy, depending on the extent, may ultimately really be able to eat normal food pretty quickly. Whereas a patient who is having a total gastrectomy will face similar issues as Dr. Sue described after esophagectomy. And that's where, again, nutrition and dietary adjustments play a key role. So, and again, I'm focusing on total gastrectomy. Those patients, again, will need to eat small, frequent meals. We will talk about different nutritional deficiencies that they may develop as a result of that. So, for example, requiring vitamin B12, which without a stomach, the patient cannot absorb B12 and will require supplementation. Also, these patients may have trouble absorbing iron and things like that. And then we'll also talk about some of the expectation or things that can occur after a gastrectomy. So one of those is something called dumping syndrome. So patients can get full, have diarrhea, nausea, especially after either overeating or eating high sugar foods. So these are all important things to think about. And I think one of the other things, to kind of remind patients is there is this big focus on nutrition, but most of the patients, with stomach cancer, not after their surgery, will also be needing to finish or complete additional systemic treatment like chemotherapy. So not only are they dealing with the recovery from the operation and how to adjust their dietary lifestyle, they're also kind of facing more treatment in addition. So that can be, kind of particularly difficult. And really, nutrition is the key to healing from surgery, getting through all of their treatment. It's really paramount. So I think, that's really a big focus for us. And, we're working on ways to kind of improve, our preoperative expectations for the patient, and preoperative nutrition in particular, because it's not just about, weight gain and getting them through the therapy, but nutrition will help reduce their complications from surgery and all of these types of things. So I think it's very important.
That's great, thank you. And I think it's also important to remember that, especially for patients who've had the back end of their stomach removed, those deficiencies in iron and B12 and blood counts is something that can be a lifelong issue. So it's something that requires monitoring even after the cancer therapy is done. So working with your primary care doctor, your oncology team, to make sure that those things remain monitored even after we stop doing surveillance for the cancer is really important. And it is for people who had any gastrectomy or esophagectomy that we monitor for nutritional deficiencies, but especially true for those who've had distal gastrectomies. So Dr. Meyer, I'm turning to you as the radiation oncologist because we know that radiation therapy is an integral component to treatment of localized esophageal cancer and can sometimes be a part of therapy for gastric cancer. So why don't you tell us a little bit about what's new in the world of radiation oncology in these diseases, and what are some of the things that excite you with respect to radiation therapy?
Sure. Thank you very much. And it's a pleasure to be here. And it's really a pleasure to be speaking to all of our patients out there. I will say, briefly, radiation can be an important component of treatment for stomach cancer, although it is not usually a part of that. We certainly do have plenty of patients who benefit from that treatment. But we more commonly treat esophageal cancer. It is a more integral component of that treatment. And we're typically treating patients in one of two ways. We're either treating patients to improve their swallowing and sometimes improve the pain they may have from the tumor in the esophagus. And then we also sometimes are treating patients in order to allow the surgical resection that they're planned to get to be more successful. And we know that that's a treatment that historically we get patients through, but it's not always so easy. They sometimes have a lot of pain or trouble swallowing at the end of the treatment. They sometimes lose weight during the treatment because it is pretty tough. It's treating a fairly large volume of their esophagus to a reasonably high dose of radiation. And we do that with chemotherapy at the same time. So it can be pretty rough for patients. And so we have been running a clinical trial that aims to improve upon that. The trial is really available at Fox Chase only. It is a trial looking at a novel technique of radiation called pulsed low dose rate radiation. Doesn't matter what we call it. The point is that it improves patients' side effects from radiation. And so we have a lot of experience doing this in patients who have had prior radiation. And if you've had radiation to a certain site, it becomes much more risky to give it again. So we've used this technique for those patients who need retreatment to a specific spot. But now we're doing it on this clinical trial for patients who have never had radiation before in an effort to decrease the risk of side effects. The particular side effect we're interested in is esophagitis, which means an inflammation of your esophagus. You get this pain and difficulty swallowing. And so this clinical trial at this point is about halfway accrued, and so far it seems to be working quite well. And we have reason to believe that this is safer, and we hope that it's at least as effective, if not more effective, than standard radiation. So that's the thing in esophageal cancer radiation that we're particularly excited about these days.
Great. So it sounds like we're getting closer to maybe having not only effective therapy, but maybe less toxic therapy for the long haul in some of our patients. So I'm going to turn to Dr. Dotan now, because I think this is, as a medical oncologist, been a really exciting year for gastroesophageal cancer. And I'm excited that we have a little bit of time for you to really talk about what's new in systemic therapy for this disease, because we have had a number of clinical trials that have been reported this year that could potentially result in some changes to how we approach both esophageal cancer and gastric cancer. And so, Dr. Dotan, in your mind, what are some of the new trials that you think are really important for patients to know about? What are some of the considerations you're taking when you have a patient with esophageal or gastric cancer, both in the early stage disease, and also in the metastatic or advanced stage disease patients?
Thank you. And thank you for having me today. It's really an honor to be presenting here and talking to all of our patients. So I'm going to start off by saying that it is great to see that gastric cancer and esophageal cancer is entering the world of personalized therapy in a really wonderful way, in which every single patient now gets extensive testing for certain markers that really identify what would be the best treatment option for them. And that includes markers that tell us whether or not they can benefit from immunotherapy, markers that tell us whether or not they can benefit from HER2 targeted therapy, And in addition, looking at some other mutations that occur more rarely in gastric or esophageal cancer, but we do see them and now starting to have treatments for them. So that's really exciting for us because suddenly it's not just one size fits all. It's not chemotherapy for everyone. There are clearly nuances to this disease. There are different types of these tumors, and thinking about how to personalize the care for each patient based on their biologic markers is really, really crucial. So I think that's the most exciting piece in this field across treatment lines. If I think specifically about new treatments or new trials that have been reported, I think the biggest advancements have been in immunotherapy. In the last year or so, we had a very large study reported for patients who have esophageal cancer and underwent chemo, radiation, and surgery. And in their surgery were found to have still some evidence of cancer. So the cancer was not completely eradicated. There was still some minimal amount of disease left over. We now know that if we give these patients immunotherapy for a year after the surgery, we can significantly improve their survival and decrease the chances of their tumor coming back. This is an approach that we've started doing at Fox Chase. I personally have a patient who is on this right now, and I think it's just so amazing to see that we're really moving the needle and being able to add something onto their very aggressive therapy that really makes a difference and doesn't add too much toxicity or burden on the patient. So that's for the early stage. For the metastatic setting, we've actually had a few studies now showing the benefit of immunotherapy in certain patients that have factors that really tell us these tumors can respond to immunotherapy. We know now that for certain patients, it makes sense to give them immunotherapy right off the bat when they're diagnosed and in combination with chemotherapy, and their outcomes are going to be significantly better than using chemotherapy alone. We also know that there are certain patient populations where immunotherapy can really make a huge difference. And maybe for those patients, it would really be the best treatment approach up front. Furthermore, in HER2 targeted therapy, so some of you may know HER2 is a target that we targeted in breast cancer years ago and started targeting in gastric cancer maybe a decade or so ago, or maybe a little bit more. And for years, we were trying to find additional therapies for these types of tumors. And we only really had one drug, but recently there's another drug that's really coming into play and seems to be very active in this disease. And we're seeing more and more studies targeting that particular pathway, which can really make a difference for patients who have HER2 positive gastric cancer. So I talked about a lot of things, but I hope you get the sense that there is really movement in our treatment options for patients, both in the early setting and also in the metastatic setting.
Thank you. I think it's really exciting. We've got, some movement in the localized setting. We've got some movement in the metastatic setting. So this is really exciting times. So we have talked a lot about therapy, and now I'd like to turn a little bit to the supportive care aspect of things, because I think, as you've heard from our surgical colleagues and radiation colleagues, some of the supportive care aspects of things are just as important as the medical techniques we use. So I'm going to start with Jalen Kellogg, who's our nutritional support person, and tell us a little bit, Jalen, about what are the important things from a health lifestyle perspective, diet, exercise, other things that you talk to your patients about in the setting of gastric or esophageal cancer?
Yeah, thank you, Dr. Denlinger. I'm very happy to be here. As Dr. Sue and Dr. Greco and Caitlin have all mentioned, nutrition plays a major role in patients with gastric and esophageal cancer. Not just with helping to maintain their weight, but also to help heal after surgery, to help reduce infectious complications, to help maintain, muscle mass and strength after surgery. So our team really tries to work with individual patients and their unique goals that they have. So not only is it important to make sure that, they're following the right type of diet? As I mentioned before, we work with them to help get them through the process of these smaller, more frequent meals, but we give them strategies on how to, make their choices more nutrient dense. We educate them on the importance of staying hydrated and how to do so by drinking in between meals so that, they're not feeling full at mealtime. So they're really able to get as much benefit as possible from those small volume meals. We also, monitor patients' weight. We make sure that they're getting enough nutrition, and, we make sure that we are following them closely enough so that our team can recommend, when it would be appropriate for some type of nutrition support if their oral diet isn't meeting their needs. So for example, we make sure that we would give the physician a recommendation when, maybe a feeding tube or TPN would be appropriate, so that we're not falling behind on the patient's nutritional status if they're not meeting their needs PO. So we really try to make sure that we're also monitoring any side effects of, different treatment methods. So as far as radiation and chemo, there's a lot of nutritional needs, nutritional side effects, I should say, that patients struggle with, including, nausea, vomiting, difficulty swallowing, painful swallowing. So we work with individual patients to give them strategies on how to combat those side effects while also meeting their nutritional goals. We offer oral nutrition supplements when patients are having trouble swallowing. We give them education on different texture modified foods, how to soften foods, how to blenderize foods at home, and just really try to hear patients' struggles. And we really want to work with them to be able to give them different options for maintaining their optimal nutrition status.
Great. So it sounds like there's lots of different options. And this is something that I know a lot of our patients ask about, is there a specific diet that needs to be followed, or is there a specific amount of activity that patients need to be doing, on a daily basis after a stomach resection or an esophageal resection? And so it's nice to know that you've got some great recommendations for people. Mm-hmm. So I'm going to finish the presentation portion with Susan Haney, who is our social worker, and she actually heads our esophagectomy support group. And so Susan, as somebody who handles a lot of the psychosocial components of patients who are dealing with esophageal and gastric cancer, what are some of the things that you address with your patients? What are some of the issues that they come across that you can help with as a social worker? And then what do you think the importance of support groups and advocacy groups can be in this situation?
Thank you, Dr. Denlinger. So a lot of the issues that have already been touched on are a lot of the reasons that I see patients after they've gone through esophagectomy or gastric cancer surgeries. And Dr. Sue and Caitlin have already touched a little bit on some of the issues that come to bear almost immediately. And that's the things that we take for granted, or at least I do anyway, is that I love the way that I am able to sleep and roll over in the bed and do what I want to do. And I love the way that, I can eat whatever I want. And these things are forever altered. These are forever altered. And so people have, different ways of, talking to me about, how that feels to have all of these things in their life now that they used to just take for granted, that now they have to change. And so we talk a lot about those types of things with them. And I think that the thing about that's important to know is that, and that they've shared with me that they feel is important, is that they do have a team around them that is supporting them, a medical team that's there that answers questions. And like Caitlin said, and Dr. Sue, we stay very, very involved with our patients for a long time. And they also have the ability to talk to other patients, not only one-on-one, but also in the support groups. And, I've heard over the years how important the support groups are for them to come together and to actually meet someone that's really going through the same thing. Because, esophageal cancer and stomach cancers are it's not that they're not common. It's just that if you go out into the world and you're talking to people and you say, oh, well, I had lung cancer, they'll say, oh, my brother Bob had that, or my aunt had that, and oh, everybody had that. But if you say, oh, I had esophageal cancer, people just kind of go, oh, it's kind of a conversation stopper. People sometimes just are not familiar with that. And so it's nice for all of these patients to be able to know that not only do they have this wonderful medical team that's always there, but we try our very best to make sure that they get connected with other patients and with their support groups so that they do have someone always that they can talk to, and this is on a monthly basis. And so that's how we try to help them along and to feel safer and more confident in their life and, know someone's there. It's always nice to be able to have a connection to someone.
I think the psychosocial component of this disease is really, really a big one. I know a lot of our patients, for a lot of people in general, eating is a social event, right? When you want to see your friends, you go to dinner or you go to lunch. And how do you do that after you've had an esophagectomy or a gastrectomy? And I think you're right. There's not as many people who are aware of what someone who's been through treatment for esophageal gastric cancer has. I know I have a friend who's been through a trimodality therapy. And I remember one day he said to me, "Do you know what they did?" And I said, "Well, yes, I actually do, because I'm a gastroesophageal cancer doctor." And it was like a light bulb went off that it was the first time that someone in his peer group actually understood to some degree. So having the support of others who know what you've been through, I think is really important.
Very important.
And also knowing that there's people in the medical group like yourself, Susan, that have that understanding as well and can connect new people with older people who have been through it.
Yes.
So
very valuable.
Yeah. So I want to thank all of you for your insight, because I think it's been a really nice sort of high level review of what's been going on in the world of esophagogastric cancers. We've actually had a bunch of questions, and so we're a few minutes early, which is good because it'll give us a little time for reflection at the end. And so I'm going to open the chat. I've been getting questions through the chat box, and I'm going to start with the first question, which is, what are some of the symptoms of esophageal cancer? And I think I'm going to actually broaden this to ask, what are some of the symptoms of esophageal cancer, as well as what some of the symptoms are of stomach cancer. And Dr. Sue, I'm going to actually ask you to talk a little bit about the esophagus cancer symptoms, and then Dr. Greco, ask you to weigh in on some of the symptoms of gastric cancer or stomach cancer. Dr. Sue.
Thank you, Dr. Denlinger, and thank you for the question. Some of the symptoms of esophageal cancer can be at first masked, and some patients may have some discomfort behind their breastbone that they become aware of. They might think it's a little bit of reflux, but they've never had reflux before. They might have some pain or discomfort in that area that didn't exist before. They might have some difficulty swallowing. The way in which they swallow may alter. They might have to force fluid down to try to get things to pass more easily. It might become severe enough that there's a blockage such that they have to actually regurgitate food or force the food up before they can get on with the rest of the day. So those are some of the symptoms of esophageal cancer. Weight loss obviously accompany a lot of those symptoms. We hope to catch patients before they lose too much weight.
And Dr. Greco, what are your thoughts about symptoms of gastric cancer?
Yes, thanks. I think, the hardest part about this is that, oftentimes these patients have very vague symptoms. So most patients, and that's unfortunately why they're diagnosed often later in later stage disease, is because, as Dr. Sue said, the symptoms are masked. Now, in terms of stomach cancer, some of the symptoms may be similar to those with esophageal cancer. Patients may have, upper abdominal pain, but most of the time these are vague symptoms. Feeling full after eating is a common complaint, or just having pain after eating, maybe not being able to eat as much as they used to. Sometimes patients can have symptoms that are similar to reflux symptoms of having an ulcer. And it's very common that patients can be dismissed as, you have reflux or you have an ulcer, take this acid blocking medication. And so, unfortunately, the symptoms are generally vague.
Yeah, so it sounds like these can sometimes be really difficult to find early on. So Dr. Abbas, someone asked a question about the association between Barrett's esophagus and esophageal cancer, and whether there's really any link between those two and how we think about that. So What are your thoughts on Barrett's esophagus and esophageal cancer?
I think that's a great question because as some of the audience may know, there's two big types or common types of esophageal cancer. There's squamous cell carcinoma, which is more common in other countries and but still present in this one. But then there's adenocarcinoma, which I really liken to an epidemic that has really become one of the fastest growing cancers in this country. And really the biggest risk factor for this esophageal adenocarcinoma, as many of you know, is gastroesophageal reflux disease. And there's been good evidence to show that it goes through steps. And oftentimes the acid reflux causes the esophagus to form this protective layer called Barrett's esophagus, which is really, if you look at it, it makes the esophagus lined with a layer that looks like the stomach lining. And it's an attempt to protect itself from acid, but unfortunately, as it produces these new cells, sometimes that Barrett's esophagus forms a bad cell. And that bad cell may actually, a cancerous cell may actually propagate and form more cancer cells and eventually lead to esophageal cancer. Now, we think that many of our esophageal adenocarcinoma patients have gone through that stage, even if we don't actually diagnose them with associated Barrett's at the time of diagnosis of their cancer. So, but it's important to know that it's a very small minority of patients with Barrett's esophagus or Barrett's disease that will get esophageal cancer. I've had patients come to me saying, oh, I have Barrett's esophagus, should I get an esophagectomy? Absolutely not. The chances are you will never even have progression of that Barrett's disease. It's about really 1 or 2% of all patients with Barrett's esophagus who will have esophageal cancer. However, they do need to be followed carefully by a gastroenterologist because sometimes we will see the beginning stages of progression. There's something called dysplasia that we look for. And I think, yes, patients who do develop progression and high-grade dysplasia, then we have to have a serious talk about eradicating that Barrett's disease.
What about for patients who may have had an esophagectomy and could develop Barrett's later on? Is that something that happens and how is that addressed, or what are your thoughts on that?
Yes, it does happen. It's partly because we bring the stomach up to the esophagus, and although it's rare, because along with the esophagectomy, we also divide the vagus nerves that are what causes the stomach to secrete acid. However, patients can have true acid reflux, and it would then will affect the remaining small portion of the esophagus up in the neck, and they can develop Barrett's. And those patients, I agree, do need to be followed very carefully, probably at closer intervals than normal Barrett's, because at the first sign of progression, we'll need to address them. Of course, we probably would not perform more surgery on these patients, but we would consider other forms like radiation.
So this is a follow-on question for Dr. Su. After you have taken somebody through an esophagectomy, what is your recommendation regarding surveillance? Do patients need surveillance endoscopies? How do you follow these patients post-surgery?
Patients are often followed by their medical team, and this responsibility may fall between their surgeon, their medical oncologist, and their radiation oncologist. They are most commonly followed with CT scans at every 6-month intervals for the first couple of years, and then the intervals can increase between scans thereafter. In terms of getting endoscopy, the guidelines vary. There are those patients who ought to be more carefully surveyed and who deserve endoscopy once a year, but there is very little consensus about surveillance endoscopy after esophagectomy.
All right, thank you. So we're going to move on to our next question, which was actually about genetic risk. So a patient, someone in the audience actually asked, in someone who has had esophageal cancer and who's gone through curative intent therapy, is worried about their kids and worried about their family members, specifically adult children, and whether this is something that could be associated with genetic risk. So I'm going to ask this to Dr. Meyer, really in terms of esophagus cancer, but also in terms of stomach cancer. Is there a genetic risk that we need to be worried about? How do we talk to our patients about familial risk?
Thank you for the question, Dr. Denlinger. So I think it's a little bit of a tricky question. We don't know that much about the genetic risk of these two diseases. In particular, there are some more rare genetic causes of gastric cancer, but for esophageal cancer, even less is known. I think it is important that we remember that some of the risk may be environmental, and some of the lifestyle choices that parents may be making may be similar to those that are being made by their children, and that may put you at a slightly higher risk. But I think that in the absence of any great data and really strong genetic component of the risk, I think that patients really should just be speaking to their doctors about their concerns about their parents and the cancer diagnoses that their parents have had. There is no sort of uniform screening for either of these diseases in this country, and I think that's because we don't have a good, effective, and efficient screening test. But I think there may be situations where the risk is high enough to do some personal screening.
Yeah, I think one of the most important things that we need to remember is that family history is a dynamic feature of a patient's medical history, and that it's not something that should only be looked at once. So as a patient, making sure that you update your providers when a new cancer diagnosis in the family is found, because it may actually change how we think about familial risk or whether a genetic risk assessment is necessary. And there are small groups of patients where stomach cancer risk may be familial, and it may not be sort of obvious with the first diagnosis. It may take generations worth, but in general, I think for these diseases, familial risk is not very well established for most patients. But keeping a good family history and talking to your providers when new diagnoses are made, I think is really important. So my next question is to Dr. Greco. And Dr. Greco, one of the things that I think has been mentioned is that for people who have more advanced disease, maybe with stomach cancer, removal of the stomach may not necessarily be recommended because maybe they have more disease outside of their stomach itself. Why not? So if you have been diagnosed with a stomach cancer and maybe been told that surgery is not a good idea, why would you not want to remove at least part of the tumor, or maybe just the primary tumor? Isn't removing part of the cancer better than not removing it at all?
Thanks for the question. So, it sounds like you're referring to patients who have stomach cancer that has metastasized, and there are different levels of metastasis. So, one of the parts of the staging workup for patients with gastric cancer often involves doing something called a diagnostic laparoscopy, where we collect basically washings from the abdomen. So we collect fluid from the abdomen to look for signs of microscopic spread that has gone beyond the stomach. And that's actually part of our staging workup. And this is an evolving field. So in general, we don't have great data to support that surgery, when the cancer is already spread beyond the stomach, offers a tremendous survival benefit. So in general, our paradigm has been, once this cancer has spread beyond the stomach itself, surgery, which is really in general a local treatment, is generally not part of the algorithm. But I will say that as our systemic therapies have improved, and now, as Dr. Dotan mentioned, the age of immunotherapy, in cancer in general, we are moving towards doing more surgery for later stage disease. I don't think we're quite yet there with stomach cancer, but that is something I think in the next 5 years is really coming down the pipeline. Patients who have done well in their systemic therapy, they may have low volume, what we call low volume metastatic disease, that potentially there is a benefit of surgery in those patients, but that is not at this moment in time really considered mainstream. But I think that is something that is evolving.
Sounds like an area of active investigation or something worth pursuing with some research dollars. So Dr. Dotan, I'm going to ask you about you've talked a little bit about subpopulations of patients and that maybe it's not just a one size fits all type of therapy. So what are the biomarkers? What are the testing of the tumor that in someone with metastatic disease, they should have done at the beginning of their therapy to sort of help with that planning process?
Yeah, great question. So first of all, I want to say how important it is to have tissue biopsy. And so if your doctor at any point says, I don't have enough tissue, I want to get more, your answer should be, go ahead. I have plenty, take as much as you can. Because these biopsies really, really help us figure out what drives your tumor. And sometimes we even repeat the biopsy after a few times because these tumors are a living thing and they can change, and what drives the tumor at the beginning of the disease may change later on. And now that we have multiple treatment options, we want to know that we're targeting the right thing. I spoke earlier about immunotherapy, and luckily we have a good marker that tells us or can help us predict how beneficial immunotherapy is going to be. And that's a marker called PD-L1. So PD-L1 is tested on your tumor sample and you get a score. It's a score that we call CPS score, and it runs from 0 to as high as you can go. We know that if the tumor score is 0, the likelihood of responding to immunotherapy is extremely low. But when we get to a score of 10 or above, we see really nice responses to immunotherapy. So that's definitely a biomarker that should be tested for all patients. HER2 is the other biomarker that I think should be tested for all patients because we definitely have a treatment that targets that particular protein. Again, that biomarker is tested on the tumor. They basically stain the tumor with a specific marker to see if your tumor expresses this protein, and you get a score of no expression to +3, which is a very strong expression. And anything probably +2, +3 is something that we would think about adding this type of treatment. And finally, the last marker is microsatellite instability. So microsatellite is a marker that tells us how unstable the tumor is, how many mutation and abnormalities it has. This is sort of an easy way to describe this marker. This is a rare thing to find in stomach and esophageal cancer. Probably less than 5% of the patients actually have this type of marker, but for those who carry this marker, they have a really excellent response to immunotherapy and really long-term survival on these drugs. So those would be my 3 most important markers to test that we have evidence for and treatment in this particular cancer.
Great, cool. So Dr. Meyer, there's a straightforward question that I think is right up your alley. If you've had radiation therapy once, can you have radiation therapy again?
Yeah, that's a good question. It really, like all good questions, the answer is it depends. So if you've been treated to a certain spot and we're interested in retreating that particular part of your body, you can get retreated to that part, but it is a little bit more tricky because when the body repairs the damage from radiation, it doesn't completely repair that damage. So we have to do different things to make sure that what we're planning on treating you with is going to be safe, and you're not going to have too many complications from that treatment. If you're talking about treating a different part of the body, then there is actually no problem with that. The radiation doses that we're worried about are not total body radiation doses, but radiation doses only to a specific site. So, we do have some options. We certainly have more options with this than we used to. I think a lot of people think once you've had radiation once, you can never get it again. And it's really not true anymore.
Great. So I'm going to ask the next question to Caitlin and Jalen, and it's really about the feeding tube and the role of feeding tubes in patients who are going through esophageal cancer therapy. So Caitlin, in the preoperative period, what are your thoughts about placement of feeding tube and when a feeding tube should be suggested? And then Jalen, I'm going to ask you to comment on sort of from a nutritional perspective, what are the things you're thinking about for feeding tube therapy, either before or after surgery?
Yeah, so that's a great question. And Dr. Sue touched on it a little bit when she talked about the symptoms of esophageal cancer, and that sometimes the symptoms can be masked. And because of that, patients present kind of later on when their symptoms have progressed so much that's interfering with their ability to sometimes even drink water. So, you know, in the most severe instances, we see patients coming to us where they haven't eaten a good meal or even any food in, you know, days to weeks, and they've lost weight really, really quickly. And, you know, with any treatment, systemic, radiation, or surgery, nutrition really should be optimized, because you're going to kind of get a little beat up, and we want you to be as optimized as possible from a nutrition standpoint so that you're able to heal and continue on your treatment plan without any interruptions. So the decision to do a feeding tube preoperatively is really on a patient-to-patient basis. And one of the biggest indicators is the ability to not just swallow your food, but also to take any medications that you need to take. We want you to be able to continue treating any other issues you have. So all of those factors go into the decision to place a feeding tube before surgery. After surgery, all patients have a feeding tube after esophagectomy. And it is a short-lived journey, but it is a journey nonetheless, and it is used in conjunction with diet after surgery. So it's to help you maintain nutrition so that, like Jalen had mentioned before, that you don't lose that, you know, muscle mass, and you can maintain your energy through your entire cancer treatment. So, you know, it doesn't really matter when you get it. It's the same tube. No matter what, and patients who have it pre-treatment will have the same tube after treatment. It doesn't get taken out. It stays in through the entire time and will be taken out once you're eating your diet post-esophagectomy.
And Jalen, from your perspective as the nutritionist, what are the considerations you have in feeding tube placement for these patients?
Okay, so as Caitlin said, post-surgery, patients with the J-tube, from a nutrition standpoint, we calculate the calorie and protein requirements for every single patient. And we do base that on their weight and based on, you know, the increased needs that these patients have for healing post-surgery. So once we determine that number, we calculate the rate that this patient will get with the feeding pump, and then what formula that they'll receive. So in an ideal world, these patients will get to their goal rate over 24 hours with this feeding tube. And then prior to discharge from the hospital, be able to be cycled off of this feed to give them some time off of the pump at home. Ideally, we want to get them down to a 12-hour cycle, and that way, you know, they can run their feeds overnight at home and then have 12 hours during the day where they can, you know, have this quality of life, have this sense of normalcy, where they don't have to be attached to this pump. And, you know, outside of this normalcy, we do notice, at least I've noticed, patients that get discharged on this continuous feed aren't actually able to give themselves proper nutrition because they just detach themselves from the pump for appointments, for, you know, just activities of daily living. So being able to get them to this cycle is really important. As far as, you know, on an individual standpoint, all patients tend to tolerate these formulas differently. So the rate that someone's able to tolerate for one patient might be different than the other one, as also based on formula. There's a lot of myths around feeding into the small intestine. So before, people used to say that, you know, you had to choose an isotonic fiber-free formula, where recent literature has actually shown that, you know, you could put a standard formula like Gevity into the small intestine and people can tolerate, you know, pretty high rates of that. So we really try to tailor the formula based on side effects as well. If a patient is having, you know, looser stools and diarrhea, actually giving them a fiber-containing formula can help to improve with those symptoms. So we work with the patient, their symptoms, their side effects, we monitor their tolerance, and choose, as far as feeding tubes and feeding formulas and rates based off of that. And then, so that's kind of how I see it from the inpatient standpoint. Once a patient is transitioned to the outpatient side, so they're discharged from the hospital, we do follow them as an outpatient as well. So Fox Chase offers outpatient nutrition counseling free of charge to all patients. So we're able to follow them throughout that process of transitioning from a tube feed to an oral diet. So a lot of times, we calculate the amount of calories that they're taking in by mouth and then can slowly wean them off of the tube feeds, just to make sure that there's no break in between that ideal number for calories and protein that the patient's meeting. So sometimes, it could be a couple weeks or months after surgery that they'll continue to have the tube, and that's just based on how much they're able to tolerate by mouth.
Great. So we have time for 2 more questions and then a wrap up. So Dr. Abbas, this was a question that actually came in before the meeting and I feel bad that I forgot to ask it. What's your opinion regarding CPAP or BiPAP or other APAP machines for sleep apnea in somebody who may have had an esophagectomy? Is there a risk regarding aspiration in this setting?
CPAP and BiPAP are called non-invasive positive pressure ventilation, and they are great tools to help when someone has an obstructive problem in their airway, like obstructive sleep apnea. But we also use it immediately after surgery when patients sometimes have trouble breathing, and it can actually ward off intubation and having to be on a ventilator. But the question comes up, well, what if someone has an esophagectomy and they have a fresh anastomosis? That means the 2 parts, the stomach and the esophagus, are sewn together or stapled together and it's still a fresh anastomosis. What happens if they swallow that air and it's trapped inside because of their pharynx? And can that cause a big problem? Well, it turns out there's been a lot of studies in the immediate post-op period after esophagectomy that have shown no patients can actually use their non-invasive positive pressure ventilation without complications. The question becomes then, what about in the long term? After their recovery, if they continue to have obstructive sleep apnea. And by the way, some have described that patients have less degrees of obstructive sleep apnea after esophagectomy. It's kind of one of the few unintended good consequences after esophagectomy, where sometimes the tissue volume in the pharynx decreases in size, and so they have less severe. However, if they continue to need it, I really don't see a complication with that. I will agree with Dr. Su, who said earlier on that they shouldn't lie down immediately after their last meal. Well, they shouldn't use the CPAP also immediately after a meal. I would give it 2 or 3 hours, but then I think it's okay to use.
Great, thank you. So one last question, and this is to Dr. Dotan. One of the problems with our therapies is side effects, as you know. We use platinum and taxanes, and peripheral neuropathy is a big issue in our patient population. So is there any progress in mitigating peripheral neuropathy or managing the side effects of peripheral neuropathy after it exists?
That's a really good question. I wish I had a really good answer for, but we definitely all struggle with this. I'm going to say that I think peripheral neuropathy is something that best prevented rather than treated. And all of us medical oncologists will bug our patients nonstop to understand how bad is the peripheral neuropathy and try to catch things before they get really, really bad. And when we do that, we can potentially decrease the dose, decrease the frequency, take a treatment break, do something to maintain it at least stable and not getting worse. Unfortunately, there are really no good options for patients who have persistent neuropathy. We recommend really making sure you have good footwear, making sure you know you take it very easy when you get up from bed or you start walking, getting rid of carpets or rugs in your house that you can fall if you don't feel the area well enough. Making sure that you use things to feel heat or when you take things off the stove. So just being more cognizant of the fact that your sensation is not as good as it was before you went on treatment, I think is really important. Some studies are looking at various vitamins that could help neuropathy, and so far none have really shown significant improvement. So unfortunately, I think this is still an area of very active and much needed research.
Thank you. So that is our time for the evening. I actually appreciate all of you in the audience for taking part of your evening to spend it with us. I want to thank our exhibitors and our advocacy organizations for participating and supporting this evening. I thank you to the survivors who sent in pictures and words of encouragement. I want to thank my colleagues who joined us tonight for this really nice meeting. We don't actually get to see each other enough in person anymore, so it's nice to see everybody together on Zoom, and I'm really glad to hear each of your perspectives. There are 4 other Together Facing events that take place virtually this spring, one on sarcoma, one on blood cancers, another on head and neck cancer and prostate cancer. So please check our Facebook page and our website for more information. And I'm going to ask Susan Haney, our social worker, to close the night with some words of inspiration about what cancer cannot do.
Thank you, Dr. Denlinger. I would just like to share a poem with everyone. And the title of the poem is entitled, What Cancer Cannot Do. Cancer is so limited. It cannot cripple love. It cannot shatter hope. It cannot corrode faith. It cannot destroy peace. It cannot kill friendship. It cannot suppress memories. It cannot silence courage. It cannot invade the soul. It cannot steal eternal life. It cannot conquer the spirit. That being said, I just want to say what we said at the beginning, which is that remember that we are together facing cancer. We are all here for you. Thank you.
Thank you. Thank you all for the event tonight, and I hope you have a wonderful evening and a wonderful 2021. Thanks.